Okay. So we're going to treatment planning this evening. We've already done all of our greetings. Now we're going to be really, really serious here. So with the treatment planning flow, we start with an assessment, right? First, we've got to assess the people who come in. Once we've assessed them, then we can do a diagnosis. Once we do a diagnosis, then we create goals collaboratively together. Like we're not their dictators. And then we start doing our interventions with them to help them reach those goals. And then we evaluate all over again. And this is the big picture for the treatment planning flow. I remembered it. I do well with like memory type helps, but everybody learns differently. Everybody has like their own way. But I caught it for myself the AD GI down here, the AD GI evaluation. So now I'm going to go into the nitty gritty a little bit more. So with that assessment, right, that's literally just gathering data. It's almost a little bit like being your own little mini research scientist. A person walks in, right? They come to get help. And even though we're helpers, we still have to gather data, right? We can't just pick a diagnosis out of our hat and give it to them, right? We've got to have evidence for why we're making that diagnosis. So we can gather the data different ways, right? It can be through interviews, through assessments, through observations. Obviously, usually it's like a combination of all of these, right? They're self-reporting, we're observing them, we're doing assessments with them, we're doing their intake interview, right? So that's all assessment is. Once we've gathered all our data, that's why I said it reminds me of almost being like your own little mini research scientist. You've gathered all this data, and now you're going to do your diagnosis. And this is where the DSM-5 comes in, right? Again, especially if you have with the insurance companies now involved and Medicaid involved, right? You're always having to give that evidence, that rationale for why is medical intervention necessary? Like why should, right? We have all these insurance companies and Medicaid. We're always needing to prove, why are they needing to pay out for this person to get this help? It's just part of modern life now, apparently, right? So then once we do that, right now, this is the part why a lot of us went to school right here. We probably weren't dreaming of making diagnoses when we originally dreamed of helping people, right? But this is where we start that journey with our client, the goal. So again, with the insurance companies and Medicaid involved and factors like that, a lot of times the goals have to be smart, right? They have to be super specific. They have to be measurable. They have to be attainable for that person. They have to be realistic, and they have to be time bound, right? So like in 6 months or 3 months, whatever, depending on the person and the intervention, and right, so many different factors. There's a time limit involved. 6 months or in 3 months, right? This reduction of anxiety or panic attacks or whatever the diagnosis is. No, the goal, I'm going to probably say this, I don't know, maybe 100 times. I've seen this checked a lot of times in questions. I guess you're trying to make sure we're clear on this, that we don't come up with the goals or by ourselves. The goals are made collaboratively between the client and the clinician. It's like a collaborative thing. This is how and this is also helps to motivate the client, right? They see, oh, this is like my goal. This is where I'm trying to get to in this journey together. The interventions, this is getting down to the nitty gritty, right? This is where these are the actual interventions we're going to do to help them reach their goals. Excuse me. So this is where we're going to match the theory where we're coming from, our orientation, our theoretical orientation to the client needs. And this is where it would be much more unique to that therapist and the client, right? So thus far, a lot of this has been like really universal, right? Like we all have to do the assessment, we all have to do a diagnosis. I've developed a frog, excuse me, out of nowhere. I'm not coughed all day. Of course, I'm coughing now that I need to record, right? Say la vie. Um, where was I at with that? Oh, right. This is where it's going to begin to get really unique to that clinician, right? So if somebody hears more CBT, you're going to be using more CBT interventions with that client, right? If somebody's more EMDR, they're going to be using EMDR interventions, right? Someone's more DBT, they're going to be doing like the mindfulness skills, the distress tolerance skills, the emotional regulation skills, right? So this is where it's going to be more based on which orientation are you coming from with your to meet your client needs. After you've done all of that, I'm so sorry, y'all. This is new here. After you've done all of that, right? Then you go back and then you evaluate all over again. So you're going to track the progress and you're going to revise the plan as needed, right? So let's imagine Konique is my therapist, right? And she's trying to help me with anxiety, right? And let's imagine she's been working with me 3 months. And so, of course, right, she's going to start going in and evaluating like, are the skills that she's been working with me on, are they reducing my anxiety? Or do we need to revise the plan? Do I need different skills? Do we need to approach this differently? So that's like the flow. I think of it like a flow, right? And it's going to basically work this way over and over, right? With our clients. Assessment, diagnosis, that's the ad part. Then the GI, that's the goals and interventions. And then finally, evaluation. Now, something else where they can ask questions can be on the actual goals and objectives, right? So I don't know if you've ever seen in, for example, therapy notes. I don't know if anyone here has ever used therapy notes, like where you work as a in helping people, but in therapy notes, like you'll see a goal and then objectives, and that actually helps to keep it clear in my mind. But the goal is what's the broad picture. That's like naming for the client the where the destination is to your journey, right? So for example, I think of it like, since we're trying to pass the NCE, or I'm sorry, can you remind me, or someone here remind me, what is the official name of the test that y'all have to pass?
The LCSW exam.
Thank you. Or that exam for y'all, right? Um, I think of that to help personalize it to like the students we're helping right here. That's like the end goal, right? We're trying to help you pass that exam. The objectives would be more like how you get there. So, for example, Dr. Pam saying you need to study 3 separate hours every day. You need to listen to her while you're driving or commuting, right? You need to show up to group. Here, that would be more like the objectives. The goal is like the big picture, right? And that's part of what will help to keep the client motivated. It's kind of like the carrot at the end of the stick, right? Like, this is where I want to be when I finish this therapy. I want my anxiety reduced. And like I said, I like to use this to help people because, like, this is why you're meeting us right here. Like, I want to, within 3 months, I want to pass this test. Well, that's the goal. The objectives is, like I said, those little nitty gritty. This is what you need to do, like, every day to achieve that goal. So that's goals and objectives. Okay. So as we're doing this whole treatment, right, with our clients, we're of course monitoring their progress, right? And we're using rating skills. Obviously, we're using client self reports, right? We're checking in with the clients. We're using our own session notes. And since we just teach the test, these are different aspects that can be in test questions right here, right? Is monitoring the progress of the client. So if the goals aren't being met, like, this is a possible question I've seen before for real, is like, do you abandon it? No, like, you would revise the plan, right? You're not going to abandon the client or just up and abandon everything. You're going to go in, revise the plan. And then, of course, you're going to document your termination planning. Like, we know, right? We're always documenting everything. Once you're going to terminate with that client, some of the more ethics type questions related to treatment planning can also check, like, do you know that you're supposed to give them an aftercare recommendations? So that would be more like an ethics type question with treatment planning is, you know, can does the person taking this exam, do they know that you don't just like cut off from your client and ship them off, right? Like, you have aftercare recommendations. Some more ethical and legal aspects that can go with treatment planning, like in the questions for these tests, would be like, some of them I know we know. It's like, you always obviously obtain informed consent before starting treatment. I think we all know that one. And I think we all know, the records are confidential. Those kind of, I think we all know those. Another one though is here. I feel like this one It's not always as well known. So if you change like the diagnosis or the goals, or like if the client needs to change, you update the plan. Like you would not leave the plan the same. And if like this one's pretty obvious in today's world too, right? Like major trouble if you don't do this one, right? You always have to be in compliance with the insurance companies and the agency requirements, right? Something else with the ethical aspects is like I was saying before, where I said I'm probably going to say this 100 times, but it's checked on quite frequently in questions. So like depending on the version of the test you get, obviously, they tend to ask some questions more than others in certain versions, but they like to check, do you know that when you are creating with your client is collaborative, the goals, when you create those goals, right, in that treatment plan, like you didn't just come up with this on your own and then dictate it to your client, right? Like this is what you need and this is what I'm going to give you, right? Whether you want it or not, right? They're going to be checking, like, this is a collaborative process with you and the client together. They're going to also, some of the questions will be more like, do you know that the treatment planning is culturally responsive? So some of the questions, even though it's like embedded in treatment planning, it can be checking, do you understand that the treatment planning should be culturally responsive to the client you're working with, right? So that they can check things like, do you understand when you create the treatment plan, you should take into account this person's worldview, their language, and their values. So all of that could be checked. It's going to check, do you know it's supposed to be evidence based? It's like all the interventions used are supposed to be supported by research. That one, like if somebody's working with Medicaid and insurance a lot, that one's usually, a lot of people know that one. The interventions you pick a lot of times, right, won't even be, they won't even be covered if they don't fall within certain interventions, right? Otherwise they're clear, like this isn't going to be covered. And then it has to be outcome oriented. So again, right, we're always going back, and some of the questions I've seen deal with that, knowing, right, like we're monitoring that progress, we're going back in and we're using measurable criteria. Okay, so it's not some like vague goal, right, but it's like measurable. And then of course we're back to, again, documentation, right? And we all know that too. Like if it wasn't written down, it didn't happen. And you're also up the creek. And you're up the creek without a paddle if it's not documented. And this one right here, right? Of course, accurate, timely, and clinically defensible. Like the way one of the good things to think about, like for the exam and just in general, right? Is this something that I could prove if I were called upon in court or were to be known publicly? Like, could I defend what I have put into my documentation, what I'm doing with my client? Clinically defensible. So now we're back. Remember, I said I was going to say this about 100 times, but if I keep repeating something, it's because it's that important to the test questions. So when the planning treatment occurs, again, I'm back to client collaboration. So one of the ways I love how this is explained is how Dr. Pam, of course, how Dr. Pam explains it, and she calls it the client buy-in. And in one of her videos, she really goes into this. I wish I could remember which one, but I love how she talks about it. I'm sorry, I'm double checking this is recording. Let's see. And yes, this is recording. Okay, thank you. Something had happened to the group last night and it didn't record. And so now I'm worried about it, right? Because I'm not sure what happened. So she calls it the client buy-in, and she's like, you know what? No one likes to be told what to do. That is totally true. And when we help increase that client collaboration, she's like, it actually is increasing the client compliance because then they feel like they have a buy-in, right? And then she also is like, it helps empower the client to feel like they have a voice. And so when you get to these questions, right, on the exam, that's one of the things to always bear in mind is, did you increase that client buy-in? Did you help to give them a voice? Did you empower them? Was there client collaboration going on? Now, some cultural considerations in some of the treatment planning questions would be like broaching and bracketing. Sometimes this can also show up in social and cultural diversity, but there are a few places this can show up, like when you're learning the content. Have y'all ever heard of broaching and bracketing by any chance? Is this something new maybe? 26. No. What about you, Jasmine?
I haven't heard of this.
Yeah. Okay.
I
Well,
haven't. Mm-mm.
yeah, I've seen it show up. It shows up a lot in counseling, but I've seen it show up in social and cultural diversity as well. Because it can't. You'll see, and I think you'll see why once I walk through it. So bracketing. I'm gonna start with that one. I think that one's really maybe easier. Bracketing. I think of it like brackets, like like this, and then inside of it, I put my values as the therapist. And this is whatever my personal values might be about anything from A to Z. When I'm working with a client, I put them inside these brackets and I put them away, no matter what they are. It could be about anything from A to Z. And I like, for example, one question I saw, like, we normally think of like really hot button issues, but it can be something we're not expecting in a question. One time, one of the questions I saw, I was like, oh, because I used to think bracketing just meant with like more hot button type issues. But the example used was like a client came in from a culture that was more collectivist, right? And the therapist, of course, was from like a Western culture that's individualistic, right? And so the question had it where this client wanted to maintain their culture. They didn't want to take on the Western culture of individualism. And so the therapist and working with them, like that's what this question was about, had to bracket their values about being an individualistic type person, right? And for example, like in family therapy, that whole thing with like having strong boundaries, right? In a collectivist culture, that does not always apply, right? The grandparents and the parents, the children might all live together. And so that was it. That's the way this question sounded, right? It was like this person from a collectivist culture and who was actually like the successful professional in his 30s, but his parents and his grandparents, like they all lived together. And that was the point. The question was checking, did you know, to bracket your values, that you weren't going to now encourage him. No, like you need to put your parents and grandparents somewhere else and you live, right? It wasn't going to push an individualistic mindset on him. So bracketing can show up in some strange ways in questions. What's going on here? Okay. All right. So that's bracketing. Okay. Now, broaching goes with it in my mind. It doesn't really, but I think of them together. Broaching is like you're in therapy and a client comes in, right? And you're different in some way. It could be in your ethnicity, it could be in your gender, it could be in, those are two of the big ones. But something like that. I think of it like the elephant in the room. Like obviously we know if we're a different gender or a different ethnicity, right? Well, in normal places, like if you're at a party or at work, normally you don't mention things like that. And that's why I think of it like the elephant in the room. We all know about it, but nobody mentions it usually. In therapy, that's what broaching is talking about. You literally mention the elephant in the room. I don't know if y'all have ever heard about this thing, the elephant in the room, but it means like elephants. You could not miss an elephant if it's in a room, right? But it's like nobody's talking about it. This, when it's talking about broaching, it means the therapist literally goes to the elephant in the room and will actually broach it. That's why it's called broaching. We'll broach it with the client, like, you know, I know like we're a different ethnicity and I might name it, right? Or, I'm like older and you're younger, or you might be younger and they're older, right? And it's going to check how they feel about it. Or gender, right? Like it will literally go to that. Like I am, a female therapist and you're a male, like how do you feel? Or if it's a male, right? How do you feel about this? So it's going to broach that topic with the client. It's going to like name it. And it's for several reasons, and you might see them in the questions because sometimes those differences can affect the therapeutic experience for the client. For one, is signaling to the client like this is a safe space for you to bring up stuff like that. It's also signaling to the client. Some of the questions I've seen is dealing with the client actually may not feel comfortable with you. Like you may need to help them find a different therapist, and they may not have known how to express that. And now you've opened that door for them. Another question I've seen is it gives them a voice, right? So like let's imagine the one with gender, right? Let's imagine if you were a male therapist. Let's imagine a client came in and she's a female client. And let's imagine she was abused as a child by someone who is male. And let's imagine she had intimate partner violence from a male. Here now she walks in and the therapist who she's ended up with is a male. Well, she actually might be struggling with that here. So he would actually go there and bring it right up with her. An example I heard actually just recently um, from a student I was working with, and I thought it was really helpful, is this student works quite a bit with um, First Nations peoples. And so she was saying someone came in and needed to work as well, and he was a white therapist, and he just directly went there straight there with it. He was like, I know, like, I'm a white male therapist, and he went right there with the clients and checked in with everybody, like, is this okay, how does everybody feel about this? That's broaching. Okay, all right. Now, two of the big assessments obviously to be familiar with and treatment planning is the mental status exam, the MSE, and the biopsychosocial exam, right? So with the MSE, I have definitely questions can definitely show up on the MSE. I remember the domains it covers with ATMOS, but that's because I work well. My brain works that way. But I remembered it by ATMOS. A was for appearance and behavior. Right, that one's pretty apparent how someone's looking, how they're behaving while you're with them, right? While you're doing the MSE, their thought processes, um, so like how fast or slowly are they talking? You know, what content are they talking about? The continuity of speech, right? Because I don't know if have y'all, I don't know if y'all have had this experience. Like sometimes you can definitely tell just by how someone's talking, like something needs to be checked into, right? You can tell it just by talking with them, like something definitely needs to be explored, right? Just based on their speech alone. Even like for example, we have an aging population, right? So even sometimes working with elders, you can definitely tell on certain days like something needs to be explored with this elder person just based off their speech. Like that alone is a good example. Now, mood and affect, they can sound similar, but they're different. Mood is what the client reports to you, right? They come in and you're check on them for the week and they're like, well, yeah, I'm actually feeling pretty happy this week, right? But the effect is what you're noticing about the client. You're noticing their affect, right? So they might be saying they feel pretty happy, but you're observing them and you might actually notice their affect seems downcast and maybe kind of depressed or really sad, right? It could be something like that. But the mood is what they report, and the affect is what you notice, what you're reporting. All right. You would also check their intellectual functioning. That's the I in at miss. Intellectual functioning. Again, right? If you're using metaphors or abstractions and you're being advised the client is not understanding metaphors or abstractions, right? Like again, that's like a sign, right? Something's here that's going to need to be explored. Like that's a flag right there. Um, okay. And then the last one is sensorium. The S in atmos is sensorium. I think a sensorium like oriented times three and the oriented by three. That's how I remembered it for my exam because there are like three main things the person will be aware of if they have a good sensorium going on. They're going to be oriented to time, place, and person. The time, the place, and the person. One of the ways I remember this is because my grandmother, she's almost 100. And on good days, right, she will be more oriented to time, place, and person. But on days when she's not doing well, right, it's like she's lost all concept of the time. Sometimes she won't know who you are. And she doesn't remember where she is. She thinks she's back in a house that she used to live in decades ago, right? So that's one of the ways I remember this is like through my grandmother. So if she's doing better that day, right? She's more oriented to time, place, and person. So that one helped keep, just thinking of her keeps me on track with this one. But the biopsychosocial exam, it's exactly what it sounds like. The bio is more like the biology, right? That's like the disease, the pathology of the disease, the genetics, the psycho. Again, that's like this one's a little bit more obvious, right? That's like whatever the disorder is, right? The anxiety or the depression, or it could be things that aren't diagnosable, like guilt and shame, right? A lot of guilt and shame, whatever is going on psychologically with that person. And then of course the social aspect. You know, what's going on with this person with their support system? Do they have family? Do they have friends? Do they have hobbies? Like what are they into? So you would do like a biopsychosocial exam. All right. Now that is like the big picture of treatment planning. Before I move on to some questions on this, and then I'm excited because then I think we'll have time to move on to the diagnosing part. Do y'all have any questions on the treatment planning flow here? No, right? I think not. Okay, I'm not hearing anything, so I'm gonna take silence as no. All right. Let's see. All right, so the first set of questions are just on this before we transition over to the DSM-5 part, the diagnosing aspect of treatment planning. Okay. All right, can you all see these questions? Awesome, thank you, Jasmine. Okay, so, okay. Now y'all tell me, do y'all feel comfortable? Does someone want to volunteer to read it, like how Dr. Pam does it, and us work through it that way? Do I have like a volunteer, or what do you think? Thank you so much, Mastermind. I appreciate that.
All right. A counselor completes intake interviews, administers standardized measures, and conducts behavior observations before selecting a diagnosis. Which phase of treatment planning is being demonstrated? So you have a counselor, they're completing intakes, they're doing standardized measures, um, they're doing observations before the diagnosis. And the question wants to know what phase of treatment planning is being demonstrated. Okay. Okay. So A, diagnoses, B, evaluation, C, assessment, D, goal formulation. So I would like to get rid of B for sure.
Mm-hmm.
Um,
Absolutely. Nice work.
and then, let's see, a counselor completes, takes away, interviews, administers standardized measures, so that's the assessment, and conducts behavior observations before selecting a diagnosis. Okay,
Mhm.
so we can get rid of D as well.
Nice job. Absolutely. So we've eliminated two, like Dr. Pim says. Beautiful. And then a small hint here that might help, Mastermind. Remember, I would say, well, that helps me is the add GI. So
Okay,
right there. Mhm.
okay, so assessment, diagnoses, goal, and intervention.
Mhm.
So which phase of treatment planning? So conducts behavior observations before selecting a diagnosis. So we're in the assessment phase. C.
Nice job. Nice job, Mastermind. That was awesome. Yes. Perfect. In Pearl on the Pearl platform and lets you do like confetti and flower petals and fireworks. I always miss that when I'm in Zoom. Because I'm like, there's no way, like, normally I would do like some confetti or something or flower petals. But yes, nice work. And then there's one more, add GI evaluation. I just do evaluation on its own here at the end. The add GI evaluation. Nice job. Okay. Does someone, all right, I'm not going to do number 2 with y'all. Okay, that's too easy. That's just checking, do you know the add GI evaluation? Like, I'm not going to insult y'all's intelligence with that one. All right, what about 3 is a good one. Believe it or not, 3 is a good one. This one can trip up people. Mm-hmm.
I can take that one.
Thank you, Jasmine.
Okay. Which of the following best represents a goal rather than an objective? So basically, which of the following is a goal and not an objective?
Mm-hmm.
All right. So A, client will use grounding skills daily. B, client will reduce trauma-related distress. C, client will attend 8 therapy sessions. Or D, client will score clinical range on the PCL5. Okay, a goal. All right.
Wait, let me know if you want, like, when you are doing these, if you want like a hint or a tip.
Okay. Um, so goal is what they're trying to obtain, and objective is, I remember you saying how to get there.
Yes, nice. Wow, y'all have
So,
great memory
well, I
skills.
wrote it down.
Oh, okay. I was like, let me know how you did. Like, I need, if you get it, I'm about to
Wrote
say,
it
if you get rid
down.
of your memory, I'm the first one in line. Like, I want it next. Okay.
Okay. So I'm gonna take out C.
Yes, nice job.
Okay.
That's way too nitty gritty, right?
Uh-huh. Um, client will score below clinical range on the PCL5. Uh, okay, I want to take out A.
Nice job. Yes, Jocelyn. I was going to say something I tell my students all the time is if you get stuck on one, like the hardest one,
Mhm,
leave that and try to eliminate like the 2 you know it can't be. Like start by eliminating the easiest first. Yes,
mhm,
right. Grounding skills daily. That's definitely not a goal. Like it's too nitty gritty, right? That's like how you get there.
mhm. Okay. And then the last two, client will reduce trauma-related stress. Client will score below clinical range on the PCL5. I'll take a hint.
Yes. Me too. I'm like, all
Because
right, now I'm
both of
ready
these
for
seem
that.
like they could be goals.
Do what now?
I said both seem like they could be
I
goals.
know. That's what I was gonna say. I was gonna say a while ago, like this is where people got stuck last night in the group last night too. They got stuck between B and D. So with a goal, remember, it's the destination where you're trying to get. It's like what's gonna motivate the client. So it's the big picture. So
Mhm.
are you, if you were working with me and you were my therapist, would you be telling me more like we're going to reduce trauma related distress, which sounds like a goal to you? Like remember I said it's like you're gonna pass this exam, or you're gonna score, like here the score below clinical range on the PCL5. Which one sounds like the
Mhm.
broad biggest picture to you?
I like B.
Yes, exactly.
Mhm.
Nice job. I know. That's why this one was hard for everyone last night too. And well, I don't know about for everyone. Some people, didn't let me know, obviously, right? So maybe not everyone, but this one was hard for a lot of people last night too. But if you get between something like B and D, go back to like what's the broadest picture? What's the biggest picture? And also what's a goal
Mhm.
you would write down for a client? Right? Imagine I come to you for performance anxiety because I've decided I have that. I'm like self-diagnosing, right? I've decided I have that. Let's say I need help with performance anxiety. And right, you would more likely, right, for my goal, you'd be like, Sarah, we're gonna reduce your performance anxiety. By the time we get done here, like it's gonna motivate me to do all my objectives to get there, but you've got to motivate me, right? You're like, yes,
Mhm.
I can help you. By the time we get done, we're going to have reduced your performance anxiety. Now, in the meantime, back here with D, right? Let's imagine that was for performance anxiety. Remember, this is more like back to the assessments and the evaluation. Yes, we're going to be using assessments, but it's not the goal, right? The goal is like that big statement of what we're going to accomplish together, what you're going to help me get done, like why I'm coming to you. It's like when Dr. Pam tells us, you can pass this test. That's the goal. And she's like, you better be listening to me even when you're in the shower. Okay, that's an objective, right? Nice work, Jasmine. Nice work on eliminating those. All right, Clinique and Jessica, one of you, like, you might want to try number 4?
Try.
Thank you.
Which statement best reflects a SMART goal?
Mm-hmm.
Client will feel less anxious. Client will explore childhood trauma.
Mm-hmm.
Client will reduce panic attacks from daily to once weekly within 8 weeks. Client will gain insight into coping skills. I'm going to eliminate D and B as in boy. D as in dog, B as in boy.
Perfect. Nice work.
Um,
Ooh, what happened? Okay. Mm-hmm.
I'm going to go with C because it seems obvious, like it's specific, measurable, and
Yeah.
everything. So,
Yeah, you're like, it's got all the works, all the smart.
yeah.
Totally. And I vote with you. Okay. Nice
Okay.
work. Yep. All right. Uh, all right, guys.
I could do the next one.
Thank you, Jessica.
Counselor selects EMDR for trauma client primarily because it aligns with the counselor's training. Despite the client expressing discomfort with bilateral stimulation, the most directly violates which best practice. I'm gonna eliminate A, I'm gonna eliminate B, and I'm gonna eliminate D, and I'm gonna pick C.
Absolutely. And you would be totally right. Okay. You would be completely right. All right. Thank you. All right. Mastermind, would you like to start us back over with a new round?
Which method is most appropriate for progress monitoring? A, well, they want to know the method that we're going to use to monitor the client's progress.
Mhm.
They want to know the most appropriate way to monitor the client's progress.
Yes.
A, re-administering the DSM-5 TR. B, therapist intuition. C, rating scales and client self-report. D, reviewing the original intake only. All right, so I want to get rid of the therapist intuition.
I know, right? If only.
Yeah, let's see.
That would be like if we were psychic therapists, right?
All right, most appropriate for monitoring rating skills. Reviewing the original intake only. Proper is the most appropriate for process monitoring.
Uh-huh.
Um,
Okay, wait just a second. I'm sorry, can y'all take this for 1 second? I'm gonna mute my end for 1 second, okay? Actually, can y'all give me 1 minute? Continue this question, Mastermind,
can't
if
see
that's okay with
it.
you. Yes, and I'll be right back.
It's not a
We can't see it.
okay. Well, did you guys hear about the therapist that got killed?
I did.
No.
Y'all heard something? No, nobody heard about it.
Yeah, in a different state. I forgot what
Yeah,
state it was in.
I forgot what state it was in too, but yeah, she got
It was a
killed.
private therapist, like she was in private therapy. I don't know if the guy like had schizophrenia and was having like command hallucinations during session, but I think that might have been the one you're talking about.
Hmm.
She was in with a client, and it was her old client. She had discharged him, and he stabbed her to death.
Oh my.
Yeah, I heard about that. That was crazy.
Yeah.
Is this the juicy gossip I wanted before I started recording?
Oh yeah, yeah. The therapist.
When we first started, before I hit record, I was like, okay, does someone have juicy gossip for
I
me?
forgot about it. I totally forgot about the therapist. Her name was Rachel White, I think.
Oh my. And then I leave and I come back and I'm like, wait, there was the juicy
Yeah,
gossip, like while I
yeah,
was gone. Okay,
I
what did
forgot.
you, I'm sorry about that, y'all. There was a
So,
noise, lots of noise going on in the background. I hope no one heard it. So,
No, we were just on current events.
okay, yeah. I mean, on my end, there was a lot of noise. So forgive me. I had to step out and try to take care of, like, let them remind everybody, like, no noise. Okay. So,
all right.
yeah. So, not B. We were saying, yeah, we're not psychic therapists. What else would you take
Yeah,
out?
I kind of want to remove A.
For sure. Yeah. And what would be the reason? What would be
It
the
says
rationale?
re-administering the DSM-5 TR. Like, that doesn't make sense.
Exactly, right? Because the DSM is just a manual with
Right.
criteria, right? Like, it's not an actual assessment. Like, we don't
Right.
administer it to a client, right? It's like a guideline for
Right.
diagnosing. Really good.
So
But
let's.
it's not an actual assessment itself.
Mhm. So, which method is most appropriate for process monitoring? Rating scales and client self-reports, or reviewing the original intake only? I kind of want to get rid of D
Good. Yes, absolutely. Nice
because
work.
it says only.
Yeah. Yeah. And think about it. Like, if you only have the original intake, right? And then let's imagine you've been working with me on my performance anxiety for 3 months. Well, you might want to get new rating scales and my
Yeah.
own report, right? Not just my original intake one, because hopefully by 3 months, you've done a lot of work with me since then, right?
Right. Right.
Nice job. Nice job, Mastermind. Okay. Jasmine, you're up if that's okay with you for number 7.
Yes. Okay. A client shows limited progress towards goals after several weeks. According to ethical treatment planning standards, the counselor should first. So basically, the question is asking, is saying a client is not progressing toward any goals after working together several weeks. What should I do as a counselor that's ethical? Um, First, what do you do first? So A, terminate treatment. B, abandon the treatment plan. C, revise goals for interventions. D, refer immediately. So I'll take out A and B. We don't want to terminate the treatment or abandon the treatment plan.
Mm-hmm.
And then take out D, refer immediately. So I would revise the goals and interventions.
Absolutely. Nice job. Yeah. It might feel tempting to do some of the others, right? But
Mm-hmm.
if it's severe enough, when someone's really not working at all with you, but yeah. All right. Clinique, if you feel comfortable, we would love for you to do number 8 if that's okay.
Okay. Which documentation best supports evaluation and treatment planning? Documentation. Okay. A, informed consent forms. B, session progress notes. C, intake paperwork. D, diagnostic code only. I'm going to rule out D. Uh,
Do you like that?
D is in dog.
D is in dog. Absolutely.
Um, what is this question asking me?
Okay. I know. Yeah. Hey, we're all there with you, right? We're like, what is this question even asking me? Yeah. Okay. So what type of documentation? So that's like a huge clue right there. Like, it's a type of
hmm
documentation. So it's best supporting, like, when we evaluate. Remember when I was saying it's like add GI and then evaluation is here. So after you do the assessment, the diagnosis, and the goal and the intervention, right? Then you are still doing evaluation, like, ongoing, right? So
Okay.
the
Okay.
wait, did that do it?
Yeah, I think it did because I was going to take out, of course, well, not of course, but I was going to take out A.
Absolutely. Oh, and that would be, of course, it would be that strong
Okay.
clinique. Absolutely, right? Even though you have to you must do informed consent before you even start treating someone doesn't really have anything to do with like evaluation, right? So yeah, I think it's as strong as you did. Like, of course, not that one.
Okay. I think I'm gonna go with B because it said documentation
Yes,
that supports the evaluation.
absolutely. Yep. And that's
Okay.
why I was saying that's one of the hints right there, that word. And sometimes I call them like cookie crumbs. Like this is like our cookie crumb right here. Documentation is part of that. The other part of this question would be like I was saying earlier, I always encourage people like take out the easiest first. Like it cannot be a
Okay.
diagnostic code only. Like that wouldn't even make any sense. The informed consent would also really not make any sense at all. Like even though you got to have it, it has really nothing to do with evaluation at all. Not with
Okay.
evaluation, right? So that would
Mm-hmm.
have left us with just B and C. But the intake paperwork, again, that's not going to really tell you like is what you're doing working, right? Like that was way back at intake. Since then,
Okay.
hopefully we've been doing some things, right? Since we did an intake. Nice work. Yeah. And one thing that really helped me, honestly, so every single question, I always did Dr. Pam's process, every single question. And then as a part of doing her process, when I was doing the elimination on the exam, because no matter how hard you've studied, it's so annoying, right? There's always stuff you don't know, and you're like, where are they pulling this from? But one of the tricks is like what we were just doing. Start with the easiest first. Like what I kept telling myself on the exam is I may not know what it is when I would get to one of those where I was like, where did they pull this from? But I know what it can't be. Right. So even if you get to a question like this, you're like, I'm not quite sure what this is, but we know what it cannot be. We know it cannot be a diagnostic code. That would make no sense. We know it cannot be an informed consent form. That makes no sense. And the last one that made no sense is intake paperwork, because that was like way back at the beginning. And now we're evaluating, which means something's been happening. So that really helped me, right? I would do Dr. Pam's process every time. And then in her, where she's always talking about eliminating, that's how we keep eliminating. Several times it's be like, oh, I don't really know what this is, totally what this is asking, but I know what it cannot be. And so I would just eliminate what I knew it could not be. And that would, end up just leaving one answer eventually. And then Jessica, if you feel comfortable, would you like to try 9? Thank you, Quinny.
A counselor updates a treatment plan after a client's symptoms worsen and a diagnosis changes. The best reflects this action best reflects which ethical requirement. A, confidentiality. B, informed consent. C, accurate and timely documentation. D, boundary management. I'm going to eliminate A, I'm going to eliminate B, I'm going to eliminate D, and I'm going to go with C.
Yes. And Jessica, I think that we should time you on your questions. I think you set a new world record. Okay. We are close to the Olympics. I feel like with those little timers they have running, I'm like, we need one of those little timers while you answer your questions. I'm like, wow, okay. My mind was like trying to catch up with you, but yes, you were totally right. Okay.
Now the next
I
one
love
I'm
it.
going to take forever now because you jinxed me.
No, that was a compliment. I'm sorry. I hope you know that. I was amazed. Like I was like,
Oh no,
wow.
thank you. I totally took it as a compliment.
Okay. I was like, oh no, I hope she didn't mean that in a negative way at all.
No, no, I didn't take it negative at all.
Yeah, I was totally impressed, let me tell you. All right. Let's see here. So now I'm so excited because we're gonna have time to now transition over to that diagnosis aspect and treatment planning. So I use let's see here. I use these PowerPoint slides from Coach Jen. So she was my coach for my cohort, but they seem to have vanished. Bear with me 1 second. I may have to hunt them down. They were here, past tense. Now they've vanished. You know what? While I find them, tech issues are beautiful issues. No, they're not. While I find them, I'm going to put back up the questions if that's okay with y'all. Evidently, it has somehow vanished, and I just have to bring it back up from a different source. Okay, so let me open back up the share with the questions. Okay. But if Jessica does the question, I can't even keep up at that speed. While I can't like multitask that fast. Mastermind, we would have been back to you if you feel comfortable. Can you take number 10 while I hunt down right quick that PowerPoint that's vanished?
Okay. Which statement best reflects appropriate termination planning? So they want to know if you know how to appropriately plan for termination. A, ending treatment. Duck, duck, go.
Oh, wait, stop share. Yep. Well, I had forgotten. You know what? That is what Zoom and Pearl are different, right? On Pearl, on the student platform Pearl, it lets me like switch right quick to bring up something different. Mm-hmm. And Zoom does not let me do that. Yeah. So it's super annoying. Okay. Okay. Oh, thank goodness. Okay. I was like, whoa, where is this? All right, here it is. Okay. Stressful minute there for me. Like, this is not very funny. All right, here we go. So I don't take credit for these. So this was my coach for my cohort, Coach Jen, and she created these slides right here. So in the DSM, right, or when you're doing the diagnosis part, just some first important vocabulary words would be like the EQ. So that's emotional intelligence, right? So you have your IQ, that's like the intellectual intelligence, right? Like that's how intellectually smarter you're according to these tests, right? According to the tests, which they have, as we all know, there's some issues with some of those tests. But this is the emotional intelligence or the EQ. And there's just a typo right here. Instead of Goldman, that's Goleman. Goleman. Okay, if you look him up. Basically, all this slide is saying is that emotional intelligence is learned. It's like a developmental process. It starts when we're little, and then we develop it from infancy, like all the way into our adulthood. And we reach different levels. And it's more, instead of like, are you smart at math or something like that? It's more of like, do you have strong interpersonal abilities? Are you really good at like, I always think of it kind of like reading the room, but not in a narcissistic, charismatic, like not like in a politician necessarily way. More like almost what we would need to be really good therapists. Can you read nonverbal messages? Do you get like those social signals? Are you empathetic? Can you be self-motivated? And so that's actually some really interesting research if you want to look it up, his work with emotional intelligence. But just for the sake of the exam, and we just teach to the test, this is basically all you need to know about that. And then some vocabulary that can definitely come up with these exams having to do with the diagnosis or the DSM part is like propinquity. Propinquity is just nearness or closeness. That's all it means. And a common example given with that is before the whole, now we have like all these dating and matching apps, right? But before that happened, most people married or they had affairs, right, with someone near to them, right? Someone close to where they live. That's all propinquity is talking about, the nearness or the closeness. And that's the most common example I see used with that. People are more likely to marry or have an affair, not necessarily because that person's like the best person that ever entered their lives, but it's literally based on partially just propinquity. That's who was there at that time and available. Then you have etiology. And if you have problems remembering that, like one of the examples I heard someone giving, I can't remember if it started with him or Coach Jen or who, but they were dealing with actually like This is part of what happens with those work affairs, right? It's just that's who is there all the time at work with the other person. It's not necessarily they're like more in love with that person. It's just literally propinquity. That's who was there all the time and available. So etiology is what causes the disorder. This is like the why. Why did serious performance anxiety begin, right? We'll just stick with that one. So it's like biological, they can go and look at the biological, the psychological, like what were the social dimensions for this starting. The psychopathology, this word is just like when they scientifically study, hear that pathology, the word pathology in there, and psychopathology, but it's when they do a scientific study of psychological disorders. Now, these words right here are bolded for a good reason. They are really commonly tested. These right here are really important. The prevalence, okay, is what percent of the population has the disorder. So you could use it, it could be like the whole, like what's the prevalence of depression in the US, but could also just be like what's the prevalence of depression at this university, right? Or what's the prevalence of depression in this community here. So it can be in different places. The incidence, on the other hand, is how many new cases occur within a given time frame, right? Such as a year or a month or however long. So like what's the incidence rate of depression at this college? So let's say we were doing like a study at a university, right? And we could first say, okay, what's the prevalence or what percent of freshmen entering this university are depressed? That would be the prevalence. What percentage of them, right? The incidence, on the other hand, would be how many new cases of depression started in freshmen within that first year of college. Okay, so that's like the difference between prevalence and incidence. The prognosis is just like, how is this disorder going to turn out? What's the expected outcome? And you could just think of going to the doctor, right? If you've ever gone to the doctor and you had a problem, well, what's the prognosis, right? Like, it's just a fancy way of being like, what's the outcome of this at the end? Like, what's going to happen to me? Obviously, the psychological dysfunction, this dysfunction, right? So something's not working, something's not going as we want it to go. So this would be like a breakdown in the cognitive or like the emotional and the behavioral functioning. Now, this part down here is really important. It's important, like if you get a question that's geared more towards like being culturally sensitive, right? So dysfunction, for it to be diagnosed as a dysfunction, for you to think of this as a psychological dysfunction, it has to be a dysfunction in its cultural context. So whatever this person is experiencing, right, that dysfunction has to be a dysfunction within their cultural context, not like your cultural context as the therapist. You would think of it as one, but if it's not one in their culture, that's all it's mentioning here. Is just be careful with that, right? Some more important vocabulary that can show up in this section is like comorbidity, and that one a lot of people know just in general, right? If you have comorbid diseases or disorders, you have two or more at the same time. Now, I'm going to skip this one for now and come back. I'm going to go next to equifinality. It's just another fancy word, just another big word to say you can get to this where you're at. Like when somebody comes into you, they could have gotten to this point by many different paths, right? So maybe somebody comes in with depression, right? Like in this example. But as you talk to them, right, and you're doing your intake interview, you might realize someone in their family died. Then they suffered some sort of disease or physical injury, and on top of it, right, maybe they started using substances to deal with all that. Another in your office, depressed. Here there is equifinality. They've wound up where they're at through multiple paths. Now, the one I skipped for a second was called the adaptive functioning. So adaptive is when we use like defense mechanisms, but in a healthy way. So, we're back to the Freud as usual somehow, right? Oh my goodness. So some of his defense mechanisms are not so healthy, right? This is talking about them in a good way, some that are considered healthy. So for example, humor, this would be considered according to them a healthy one. Sublimation, right? I don't know, does someone here remember the defense mechanism sublimation? Does that ring a bell with anybody? Yeah, Jessica, do you feel comfortable sharing that with us?
Yeah, it's when you take something that's not socially acceptable and you do something that is socially acceptable. So instead of like punching somebody in the face, you then go boxing and you punch a bag.
Absolutely. Thank you. Yes. And the one I always find troubling, right, and disturbing, and I'm like, I hope that's not true, is the one where they say you want to secretly cut up somebody so you become a surgeon. And I was like, I hope that's not true. That makes me disturbed, right? Uh about my surgeon. I was like, that concerns me. I hope that was not true about this person, right? So now the next bullet point, thank you, Jessica. That was perfectly explained. The next one here, failure to regulate stress may lead to a break with reality. So this is just an important note here because sometimes if we think of psychotic symptoms, we might instantly, like in this section 4 question, go to like schizophrenia, right? Or if somebody's having psychotic symptoms when they're in a manic state with bipolar 1. And this is just making a note that um somebody can be having psychotic distortions or delusional projections, even, right? See here, there's no mention of schizophrenia, there's no mention of mania going on, right? Just a failure to regulate the stress. If the stress becomes overwhelming enough for that person, that can lead to a break with reality if something that terrible starts happening to this person, right? So I like putting this out so that people are just careful. It's like Dr. Pam says, I never get over it. She is like so right. It is a reading test. Like it literally is a reading test. So when you're reading the question, right, just make sure, like, is it mentioning um symptoms of schizophrenia or mania with bipolar 1, or is it mentioning something more like this where they're just, right, it's led to a break with reality, and it's like sounds more like this description here. Now, some more important words that can definitely show up, like I've seen these frequently, would be ego dystonic and ego syntonic. So if it's ego dystonic, it's like, I like how Coach Jen says this, I don't like this, I don't like it. So it's like OCD. The person knows they have it, like they're very aware, and like they're miserable. A lot of times they want to get help, like they are miserable. And the difference is with ego syntonic, this one's in sync. It's in sync with how that person feels as a person, like their ego. And a lot of times that's one of the reasons they actually cannot really get help for real, is because they don't see a problem. To them, there is no problem. To them, everything's fine. And the perfect opposite of the OCD would be OCPD, right? So, like if someone has OCPD, obsessive compulsive personality, the personality disorder, if you talk to people who have known them their whole lives, they will tell you, like, no, this is just that person. Like at 2 years old, they were like organizing all their blocks and shoes, right? Like this has always been that person. And maybe exaggerated a little bit, but it's kind of like that, right? Another one that's like this will be anorexia. And that's was actually another reason why it can be so hard if someone has anorexia, because they actually perceive this trait as like acceptable, like this is in sync with who they are as a person. And then I'm going to let y'all, like, because I'll share these slides in a second, I'll let y'all go back through that. That's just what we were dealing with earlier, the MSE, the mental status exam. Same thing with the biopsychosocial. That just gives you like more vocabulary that you may see that goes with that, right? Describing that more in detail. Also the psychological, these are just common psychological assessments to be familiar with, right? Like the MMPI, the Minnesota Multiphasic, right? I don't know if you've heard, I don't know if you've heard Dr. Pam say that this one is just to see how crazy you are. That's how she remembers that one. She's like, this is the one that sees how crazy you are. Dr. Pam says that one. It always makes me laugh. And then of course you have the intelligence test, right? The WACE, the WISC, and the WIPSI. I remember Dr. Pam says for the WIPSI, right? She says, remember it by the little tiny kids, they still pee pee, right? So WIPSI. So that's how I think she says on themselves. I think she says that's how to remember that one. Now up here, back up here, the projective test, the Rorschach, the TAT, the incomplete sentences, those all go more like the psychoanalytical or the psychodynamic. And it's called projective, right? Because it's considered, according to like this approach, psychoanalytic, is considered that we project onto those tests. Yeah, it's called projective. We project onto that test from our unconscious. Remember, Freud was always like trying to access our unconscious and get in there and see what was there, right? So that's how I think of this and remember it. So with a Rorschach ink blot, right? You look at that ink blot and you're like, according to this, projecting from your unconscious onto that ink blot. Same thing with the tat. The tat uses pictures instead of ink blots. And the same thing, you would be shown a picture, and again, you're like projecting onto that picture from your unconscious, and they believe it's telling them things about you, right? The thing to watch out for, I don't see it here, is also subjective. So these three tests right here, Rorschach and thematic for sure, are both projective, meaning what I just said. You're projecting according to them from your unconscious onto the ink blot or onto the images with a story. But it's also subjective, meaning it's open to interpretation, right? With the therapist. I mean, think about it. If I go in and I say to them, this ink block looks like, some demonic moth, right? And then Jasmine goes in and she says, this looks like some beautiful butterfly, right? And then couldn't hear it. Like each of us can see something different. Well, let's imagine Mastermind is the therapist and Jessica is the therapist. Here, with each of us as the client and with Jessica and Mastermind as the therapist, it's completely open to interpretation. Jessica may have one interpretation as a psychodynamic therapist, and Mastermind might have a different interpretation. So if you're on the test and you get a question about it's subjective, that's the subjective part, meaning as the therapist, Jessica and Mastermind it's open to interpretation to the therapist, how they interpret that. The projective has to do with the client. We're projecting onto that from our unconscious. So that can be easy to get confused. Those tests are projective and they're subjective. I'm going to let y'all go over this more on your own. I think this is not difficult. It's just being familiar with it, right? And I'm going to skip these for a second. You have to know, like the MDD, major depressive disorder, it takes 2 weeks of having it. So for some of these disorders, some of the clues that will be in the question will literally be the time frame, the duration, right? A good example I'm going to show you next is like bipolar 1 and bipolar 2. Okay. So sometimes part of the clue given, and cyclothymia will be the time frame. In fact, wait, I want to leave that for a second. There's even one that can be more, where is it at? Schizophrenia. I'm going to go here next. So for example, what I mean by, and then we'll go back in a second, what I mean by sometimes like you have definitely got to know the duration of the symptoms to get the question right. A perfect example is the schizophrenia. So for example, if someone comes in and they're having delusions and hallucinations, right? Let's say you get a question on the exam and this person's having hallucinations and they're having delusions, right? And you're like, oh my goodness, this sounds like schizophrenia. This question sounds like they're describing schizophrenia. Well, actually, maybe not. It literally is going to be determined by how many days they give you in the question. So if somebody's been having these schizophrenic symptoms here, but it's only been for around 3 to 30 days, I have seen before 1 to 30 days, but you get the idea. It's up to 30 days, right? That's going to only be brief psychotic disorder. It is not yet schizophrenia. No matter how much it sounds like schizophrenia and the question you get, it is not schizophrenia yet. Once it hits the 31st day, so literally the 31st day, like that 1 month, then up to 6 months, then it becomes schizophreniform. It's still not schizophrenia. Like if you had this question on the exam, you still would not pick schizophrenia as the answer. It would be schizophreniform. Finally, if someone's having these symptoms and in the question it says 6 months or longer than 6 months, then the answer would be schizophrenia. So that one, I'm going to put my laptop in. That's one you got to be really careful with, where you have to literally know the time frame required to diagnose to get the right answer, because the symptoms are all the same. The only difference is how long has the person been having the symptoms. So that one right there, like, can be tricky. So that one you definitely got to know, like, duration. Another one like that is, where is it at? Interesting. Is it not here? Here. Trauma and stress related. Another one That is like that way you've got to know like the duration to pick the right answer is acute stress disorder compared to PTSD, right? So let's say you get a question on the test and something it's obvious something very traumatizing, they describe it in the question, right? And then the person's having like flashbacks and nightmares and right, they're describing PTSD like symptoms. Well, if it's less than a month, if it's like from 3 days to about 1 month, it's still not PTSD. No matter how much it sounds like PTSD, it is not PTSD yet. It will be acute stress disorder. If in the question they describe trauma and all these PTSD symptoms, and it says it's been a month or longer, now it's PTSD. So that's another one where the symptoms will be the same. The only way to get the answer right is to knowing the time frame, how long, right? So when you see these questions, really look for like how long has the person had it in the question. That will be part of the clues. Okay. Now going back up to bipolar. Okay, first I want to point that out because that one, some of them are not quite that strict, right? Like for example, I'll show you what I mean with the bipolar 1 and 2. Like you need to know how long the person, like you need to memorize that part, like right here. See, like major depression, blah, 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 like the mania for bipolar 1, 5 to 7 days. But here's the thing, if you get a question and if it describes mania, like true mania, like mania, you're already done, no matter how long. Like if it mentions hospitalization, you're done. That's bipolar 1. So only bipolar 1 has manic mania, like all the way, even one episode. That's bipolar 1. Bipolar 2 will only be hypomania. It never will truly reach manic level. So for example, right, when Dr. Pam's talking about it with bipolar 1, when somebody's in mania, like you cannot miss it in the questions. The person will like, I mean, it's extreme behavior, right? They'll be up playing like video games all night, every night, right? They'll be spending everything they ever saved. They'll be sleeping with everyone they know. Like it will be extreme. Like a lot of times they'll wind up needing to be hospitalized. And sometimes that will be the clue in the question. It'll say, hospitalization required. So that's like bipolar 1 mania, and bipolar 1, that's your giveaway. If it's bipolar 2 hypomania, Dr. Pam gives the example of herself. I don't like for fun, not her having it, okay, for fun. She's like, it would be like if she went into work and she's like, oh, like Pam goes to work and she decides to buy coffee for everyone that day. Here, like she's like, if you didn't even know the person, you might not even know they were having hypomania. They're just slightly higher than usual, right? If you didn't know her, you might just think, oh, wow, this person, right? They're just giving free coffee to the office, right? It's like a much lower high. It's just hypo, HYPO, hypomania. So definitely know the time because the time can be used for this, like mania and bipolar 1, 5 to 7 days. For bipolar 2, it's 4 days or less. But like I said, when you're reading the questions, if you see like true mania, describe you're already done. Like that's only bipolar 1. Now with the bipolar 2, it has only the hypomania, but it will have 2 weeks of major depressive disorder. Okay, so 2 weeks of major depression with the hypomania. Okay, here's the strange one, just to back up for 1 second. On the test, sometimes they will still ask, what is this treated with? I feel personally like I don't see a lot of people who get questions like that specifically, but once in a while I'll meet somebody who does get a question like that. And it seems to be quite frequently on the test, you still will have, the answer will still be lithium. So that's why that's highlighted. They also, sometimes the answer has been Depakote. So just kind of be aware of this right here. Like I said, I don't meet many people where they frequently get that, but once in a blue moon, I've met somebody who got a strange question like that. So that's why those two names are there. Now, along with bipolar 1 and bipolar 2, there's now something called the cyclothymic. And Dr. Pam, because, I just adore Dr. Pam, right? She's always trying to help us find ways to remember. She calls it the baby bipolar, right? And she calls it baby bipolar because it never goes up to full mania. It's like a little up. It's like this little wave. It goes up and it barely goes down. It's like little tiny waves going back and forth. You'll go kind of up and then it'll go kind of down, but you never reach true mania and you never reach truly major depressive disorder. You're just going a little high and then you're going a little low and you cycle. That's why it's called cyclothymic, because it cycles back and forth. No, this is so annoying. We're back to those needing to know time frames, and those can be so hard to remember. That's why I was like, it's so annoying. Again, sometimes the clue in the question will be how long has the person had it, right? If it's adults, it takes 2 years. The person had to have been experiencing this for 2 years to be diagnosed. If it's in children or adolescents, it's 1 year. So that's something useful to kind of stick away in your memory. Okay. All right, guys. I think the rest of these, right? I think a lot of us know the anxiety disorders. Oh, another useful thing to remember is the anxiety disorders almost always, you see right here, often treated with CBT. In a lot of the questions, that will be the answer. Treatment with CBT and or medication. Okay. Now coming back to schizophrenia for a second, right? You have delusions, that's more your thoughts, right? And you have hallucinations. When you have the hallucinations, just be careful with that one because it can be in any of the five senses, right? It can be something you hear, something you feel, something you smell, something you taste. It can affect any of the five senses. And one of the reasons I say watch out for this one is they just use two of them are kind of funny, like the long words for them. Instead of using smell, they use the word olfactory. The way I remember that is we have an olfactory nerve that has to do with us smelling, right? That olfactory nerve. And so that's one of the ways I remember it is there's literally a nerve called the olfactory nerve. So there's olfactory. So most likely they won't give you the word smell. If someone's having a hallucination with smell, they'll use the word olfactory. Another one to watch out for is most likely they won't use the word taste. If someone's hallucinating with the tasting, they'll use the word gustatory. I know some funny words, right? So olfactory and gustatory, okay? With the delusions, okay, these are three of the most commonly seen. Like there are more delusions than this right here. Like if you look it up, there are several more types of delusions, but these are three of the most commonly seen. The erotomania is highlighted. That one's seen quite a bit. And another thing to watch out with that one is what's called the idea of reference. Does someone have any idea what they think the idea of reference means with erotomania? If someone's having a delusion that's stemming from erotomania, what do you think the idea of reference would mean?
It's like maybe if you see something on TV and they mention something, you think that they're talking, that message is for you. They're talking to you direct.
Totally. Thank you, Master Frank. Absolutely. Yeah. Somebody can be singing a love song as usual, as they do all the time, right? But this person, if they're having an idea of reference, they will think, as Mastermind was saying, that that person is literally talking to them, that they're trying to send like this secret message about their love for them and they're going to come be with them. That's why it's called the idea of reference. They think it's referencing to them specifically out of everybody on planet Earth. And then, of course, you have the grandiose. I feel like that one's kind of obvious, right? And then persecutory. Okay, what a word. I hope I just said that right. So this one, obviously, they think they're being persecuted, but it's at the level of, this isn't like just a paranoid personality disorder. Like this will be at like the delusional level, okay? And there are more. You can look them up. These are three of the biggest ones, which is why they're on the slide, like for the test, okay? I don't really meet many people where this has been like something they saw. What do y'all think? If y'all have taken the test before, one is called the folia de, and that's if two people are sharing like these delusional beliefs right here. And often like one will be influencing the other. Folia de is just it's French, so it's like dealing with two people are having this crazy belief together. Have any of y'all seen this one before?
Yeah.
You have. Is that
Have.
yeah? Okay, yeah. So it's just here just in case, like Another one I don't hear many people saying they've seen, but it's here just in case, is still on the exams. Like if they ask for an antipsychotic, it's generally going to be Risperdal. But like I said, I wouldn't worry about that. I've not seen many people ever mention they saw this. Another one you might see is, okay, if you get a question where they're taking the antipsychotic and they have a facial distortion. The antipsychotics can cause facial distortions. This is this TD right here, that shortened stands for tardive dyskinesia. That's all that stands for. So once that happens, then they give them another medicine, right, to try to get rid of the facial distortion, and that medicine will be called cogentin. But like I said, I wouldn't, that would be the last thing I'd stress about out of this section. Okay, the main thing I would stress is the other stuff I was first talking about, like those time frames, bipolar 1, bipolar 2, the schizophrenia time frames, right, like between brief psychotic disorder, schizophrenia form, schizophrenia. You definitely want to know that. The other thing I'll point out right quick, and then we're going to try to work some questions on this section to, like, as our last work today, is oh guys, remember how I was saying a while ago, a lot of times for the answer, if you get a question like which therapy will be used or what would be effective, I said it's almost always CBT or CBT and medication. One exception to that is PTSD. With PTSD, the answer will be EMDR. Okay, that's why the if someone has this EMDR. Okay, and let's see here. Right here, so you have, once in a while too, you might see a question where it's more like broad. You have like the neurodevelopmental disorders. Neurodevelopmental is more like neurodevelopmental is more like kids. Right here, the word developmental in there. So this is like the language disorders, the autism spectrum disorders, the ADHD, the intellectual disabilities. If you get a question where it's broader like this, those are more like neurodevelopmental. Neurocognitive, on the other hand, those are more disorders that usually affect adults, right, like Alzheimer's and Parkinson's and the delirium, right? So that's something to watch out for too when you get to a question. And then you have the personality disorders, right? Oh, by the way, this is a question that can pop up. That's why it's right here, this DBT question. Sometimes it'll ask the question like, what was DBT, like which population or which mental health disorder was DBT originally created for? Like DBT is now used for tons of different things, right? But it may ask like, what was it originally? Why did Marshall Linehan originally create DBT? If you get that type of question, this would be the answer. It's borderline personality, or BPD. That's the population she originally created DBT for. Okay. And this is just here because, you know, it's easy to get schizoid and schizotypal confused sometimes, right? Because they kind of sound the same. But one of the main differences, like schizoid is a loner and they actually like to be a loner. Like they don't even want friends, but their reality is intact. They don't have any like quirky, I hate to use that word. They don't have anything like, I'm going to stick with this. The reality is usually intact, right? But they just truly want to be alone. Versus schizotypal, they actually want friends. It's actually really sad. They actually want friends, but because they have some like odd behaviors, and like it said down here, they may have magical thinking or odd beliefs. It's hard for them to actually keep friends. Once people begin to hear like some of their magical thinking or beliefs, then it can actually be hard for them to keep friends. So that's why this is here, because sometimes people get these two like flip-flops, schizoid and schizotypal. These go in the personality disorders, and they are definitely different. So for example, Dr. Pam, if I remember correctly, one time was talking about someone she knew who's schizotypal, and he would wear like earphone, no, what are those things called? Earmuffs, right? Like literally in Florida, like with hot weather. But he would be wearing earmuffs because of some like magical or thinking he had. But notice it doesn't say they're hallucinating or having delusions on the level of like a brief psychotic disorder, a schizophrenia form, or schizophrenia, right? Remember that whole slide we went through a while ago? It's not to that degree, but it still is odd enough where it will make it hard for them to maintain friends. So those are two to watch out for as well. because they can all begin to sound the same, right? When you're under stress on the test. Okay. Now, we are going to go to some questions on this. That was a lot, okay? That was a lot. How are y'all feeling on that? Okay. That either means we reached saturation point. does that does that mean that that was our limit of learning, right there, right? That's a lot. And there was more, right? Those were some of the main points. I've people can tend to get like swapped around. Let's see here. Oh, you know what? This will give us a small mental break. I'll go ahead and put in the chat. Let me see if is this gonna let me do this. Okay. I'm gonna put the link to this PowerPoint, and if it's okay with you, could one of y'all or all of y'all or something click on it and see if this link is gonna let you in?
I'm in it. Well, I'm not in it. It just basically is asking for permission, and then you're just looking. You need access, so basically you're just requesting access as a viewer, commentator, or editor.
Could someone request access right quick? Is that okay? And let's see if I get an email for it.
I just sent it.
Thank you.
It won't allow me to go into it.
It's not allowing you in at all. Oh yes, Jessica, I see you. So no worries. All right, if Jasmine, okay. Let me go ahead and make sure y'all can get this. Okay.
Okay, it looks like I just got it.
Awesome. Okay. No, and then who was not able to access it? I want to make sure everyone has what they need. Because I know me with my memory. At the end, I'll end up forgetting something. Did Mastermind, did it ever work for you?
No, it won't let me in.
Don't mind at all. Don't worry at all. Let me see. If you feel comfortable, Mastermind, if you just want to, if you want to just email me, I can just send it to you that way as well. Okay. If you feel comfortable, just shoot me an email and I'll just email it straight to you if you feel like it would help you. Oh, do y'all also want the questions? What do you think? That we were working? Do you want the rest of them? Or maybe no, maybe not. Okay.
Yes,
Yeah.
please.
I do.
Okay. Let me see here. Now we're going to new questions. Okay, so these new questions are on diagnosing. It's on the DSM-5. Okay, like so that's where we're heading next. Okay, let's see. Can you see this? I'm assuming that's yes. Okay, so if it's okay with y'all, we're gonna do.
Could you make it a little bigger?
I can definitely try. Let's see here. View. All right, is this getting bigger for you all?
Yes.
Cool. Is this going to be good right here? Okay. So are y'all good with the last rhythm we had going? So with that, so Mastermind, you would be up first. Does that feel good for you?
Oh yeah, that's fine.
Thank you.
All right. When a therapist speaks of a probable outcome in a case, he or she is technically referring to. So they want to know if you know what a probable outcome is. And so we have A, the prognosis, B, the diagnosis, C, the intervention, D, attending behavior. The probable outcome, so I'm going to get rid of D.
Nice word. Oh.
And then C, get rid of C.
Mm-hmm.
So the probable outcome, I believe, is A, the prognosis.
Nice job, mastermind. Absolutely. I was trying to, this is not letting me like edit, but that's okay. Okay. We can do without that. Yes, absolutely. Nice work. And then next up, oh, by the way, mastermind, if it's okay if I ask you, what would be some examples of attending behavior? So one trick, like as you get closer and closer to the exam and you know more and more content, one thing I've noticed that really helps is like when you're going through questions, can you answer why it's not the other ones? Like what are the other options? Like what are they talking about? So what are some examples of like attending behavior?
I'm gonna guess because I'm not sure, but I would think that attending behavior is maybe the behavior of the attending whoever's it's like the attending therapist or physician.
Mhm. Yes, absolutely. Yes, the therapist, exactly. Well, in our case, a therapist, right? Yeah, like, 'cause I'm not trying to be a physician here, but yeah. So it's like you show you're like fully present, you're listening, you're engaged with the client, right? It's one of those like basic counseling skills. So it's letting them know like I'm here with you, you matter, right? Thank you. That was great. Oh, let me see. Wait, there's something that goes with that. Oh, like literally, sorry, it's like pretty basic eye contact, right? So if you're working with your client and you keep like looking off and like your arms are crossed and then you fidget, right? That would not be attending. Attending is like really engaging with eye contact, with like your body language, like your facial expressions. It can be that, which is nonverbal, and then it can also be verbals, like I was saying, like I see. Here, because they're the ones actually talking, like you're attending. I see. Right. You're letting them know that got all scrambled. You're letting them know like you're fully there with them
Okay.
in every way. Nice work. Okay. So whoever, let's see, was it Jasmine?
Mm-hmm.
Okay. Let me scroll this down.
Okay. A therapist on an inpatient unit conducts an intake with a 40-year-old man who was transported to the hospital by the police after an altercation in the park. He is unable to provide a medical or social history and reports having no memory before he arrived at the hospital. A police check reveals that he is an executive of a large company in a nearby city who was laid off a few days ago. At the end of his week-long stay in the hospital, he has recovered his memory. The most likely diagnosis is okay. So there's a patient on is an inpatient
Mm-hmm.
coming in for an intake with a therapist who came by police after some altercation. He cannot provide medical history, social, and he has no memory before he arrived.
Mm-hmm.
He's an executive who was just laid off.
Mm-hmm.
And then at the end of the hospital stay, he has recovered his memory. All right, so A, dissociative amnesia with dissociative food fate. What is that? Boog?
Yeah, fugue.
Boog?
Yeah, I know you're
Fugue?
like, what
Okay.
is it? Yes, nice work. It's just one of those strange
Okay.
words. That's like me while I go. I was like, wait, I totally blanked out on how to say persecutory. I still don't think I'm saying that word right. So you're fine.
Yeah. Okay. B, factitious disorder. C, PTSD. D, acute stress disorder. Um, I'm going to take out B, factitious disorder,
Yes, good.
and then take out C,
Mhm.
PTSD. I'm going to go with D, acute stress, because um, he was laid off a few days ago. I believe that's from 1 to 30 days, right?
Oh,
Or
great
less,
on the
no?
okay, on the time. Yes, acute stress disorder goes up to like a month, right? And then after that would be PTSD. So great on the time. So you got rid of B. That was good. You got rid of C. That was good. But I'm going to give you a hint here,
Oh,
Jazz. I know that fugue was actually important. So you're fine. This was
okay.
a hard one, and I didn't go over this one. So this is one of
Yeah.
those like you're like came out of like nowhere, right? So
Yeah.
if you go back up to the question, you were right. He had something stressful happen. And then where was the 30 days at? I don't see a time mentioned. Wait, do y'all see a time mentioned in here? Other than
I
like
just saw
a
the laid
week,
off a few days ago.
right? Oh, at the end of his week-long stay. Those are the only two times we're given. But
Hmm.
what gives this away is okay, I'm gonna calm down. Part of this is fluff.
Memory.
Yes. Part of it's fluff where it says right here, he has no memory of any of his history. That would be the dissociative amnesia. He actually even doesn't even know who he is. So if somebody's suffering from a fugue state, this is common where they literally have no idea who they are. They might even
Hmm.
go start back over somewhere as a new person. They literally do not remember who they are. Like it's really sad. Um, I mean, this really happens. I was reading of a story like this of someone who was, I believe, a teacher, and she vanished. And it was like, where was she? And she had restarted life as a whole new person. She had no memory at all of her previous life having been a teacher at all. Um, so yeah, so that would be what gives this away right here. He did suffer. Where does it say right here? A police check. See, he was laid off a few days ago. So that at
Hmm.
first, like, oh, was that? But that's not actually a traumatic event, right? So for acute stress disorder or PTSD, the person had to have suffered like something traumatizing, like being threatened or seeing someone they love threatened to death or close to death. Here is like on trauma level. This is just like a stress or trigger. But that
Hmm.
right, something that's stressful can trigger a fugue state for people if they have this right here. The other hint, by the way, if you get a question like this, is at the end of his long state, recovered his memory. So sometimes if somebody's been suffering with like dissociative amnesia where they forget and then dissociative fugue, they don't even remember who they are, their memories can come back. Sometimes like it will come back and they'll like remember their history and who they are. Nice work, Jasmine. That was a hard
Okay.
one.
Yeah, it was.
Because we
And
had
I always miss these types. I don't know why I mix up stress disorder with the memory stuff. I don't know why.
that is okay, except not on the test. It's not okay on the test, right?
Yeah.
Maybe, maybe they're from now like, okay, if you go back into the question, let's imagine sometimes I have my students do this. I'm like, how could you have gotten this right? Let's say, even if you didn't totally know what this was, right? Let's imagine you're on the test and you got a question like this, and you didn't really truly know what dissociative fugue was, but you still could get it right. Believe it or not, you
Hmm.
still could get it right because in the question, nothing traumatizing is mentioned. There is no trauma. He lost his job, but that's not considered trauma. Or he was laid off, right? So from that
Hmm.
alone, you would have known it can't be C or D. It can't be fat. If that's when somebody just makes it up, when somebody has a factitious disorder, they literally just make it up. And they do it intentionally, by the way. It's not like this where they forget. They intentionally assume to be sick, to have some sort of disorder. So
Okay.
yeah, so that's one of the tricks when you're answering questions, y'all, and you get lost like that. It's hard to calm down, but try to calm down and be like, wait, even if I don't totally know what it's talking about, what can I figure out from this question from the little bit I know? And we know that acute stress disorder and PTSD require something traumatizing to happen. Not just like losing your I'm not putting that down. Losing your job can feel traumatizing, right? But they mean like on like extreme levels like death or other extreme things, right? Or or near to death, right? Like almost dying, like and other things on that level, being in a war zone and almost being bombed, right? Stuff like real like trauma or sexual assaults, right? Or seeing someone you love that happens to them or someone you care about. Nice job, guys. These are a little harder. Okay. So, oh, Clinique. Would you like to take this one on for us?
Mm-hmm. A
Thank
school therapist receives a referral for a 13-year-old boy for inattentive, and poor grades. During observations and interactions with the student, the therapist experiences the boy as intelligent and highly verbal, but notes that he has difficulty following instructions and reports that he avoids reading and writing activities. The initial diagnosis is most likely. I'm going to take out A, conduct disorder,
Mm-hmm.
and I'm going to take out the autism disorder.
Yes. Nice work.
I'm going to go with B because inattentive was in
I know.
the,
I know that's what at first when I saw this, I was like, oh. And then like if you keep looking, wait. So do you see how it says he has inattention, right? And poor grades. Okay. So that inattention at first with I'm thinking with you too. I'm like, this is ADHD inattentive, right? Because it says clearly he's not paying attention. But then if you keep reading during observations and interactions with the student, actually the therapist is realizing, right, this boy is highly verbal, like something's going on here and intelligent, but he has problems following instructions. That still can sound like ADHD inattentive, right? Because
yeah,
I know, right? It's like because I definitely know several people with this, and I mean like diagnosed with it, not just us being funny about it, right? And reports that he avoids reading, but right here, he avoids reading and writing activities. I'm saying these questions are tricky, okay? And this is why Dr. Pam says, I know I keep saying it, but that's why she says it's a reading test because I'm there with you up until here. Everything thus far, I'm like, this must be ADHD with inattentive.
yeah, because everything, but the reading and writing activities, I'm like, is it
Yeah,
because he's getting up out of his seat? I don't know. Like,
I know. And I'm there with you, but that's why Dr. Pam says do not add to the question. You know how she says this like all the time,
mm-hmm.
not add to it or don't put yourself. That's why this changes literally the whole question right here.
Okay.
He avoids so everything like he's very intelligent, he's highly verbal. At first, I'm there with you. I thought it was B, and then I saw this. He avoids reading and writing. Very here when they get that specific, like that's a red flag to like slow down with the question. He avoids
Okay.
here reading and writing. It's something very specific. It's and it might I have to say one of the reasons this might help me as someone I know really well, they have dyslexia and they're actually above average intelligence, like very verbal. But this is one of the things when they were young, at first people thought like this right here, like something was like wrong in air quotes, right? But it was because they had dyslexia. So the answer to this would actually be D. It's going to be a specified learning disorder.
So
So
a specified learning disorder is something like dyslexia, or what else could it be?
how do you say this? Dyscalculia. I don't think I'm saying this right. Can someone help me?
I
Dyscalculia.
thought it was
Yeah,
dysgraphia or dyscalculia. I mean, it's
dyscalculia.
when you have issues
Yes,
with numbers.
dyscalculia. Thank you. Yes, that's what I
Calculus,
was just
yeah.
saying. I can't remember if you say dyscalculia or dyscalculia. I was like, wait, is this like calculia? Okay, thank you, Jessica. But yeah, it's like what dyscalculia is another one. I know somebody with that one as well. I'm not sure. I'm trying to think if I've ever met anybody with a dysgraphia. Have you, Jessica? No, I know someone with dyslexia. I know somebody with dyscalculia, but I'm not sure if I know somebody with dysgraphia. Have you ever met somebody with this?
I forget what it's for, but I think that is it related to numbers as well when you're putting numbers in stems?
Um, wait a minute. Dyscalculia is to do with the numbers. Dysgraphia, I think has to do with writing abilities, Jessica. I think it has to do with like the writing ability.
Yes.
Like they problems with like forming the letters clearly, writing them neatly.
Yeah,
Right?
you're gonna need like OT and PT to like hold your pen and stuff for that
Yes.
one.
Yes, this is more like the literal writing it on the paper.
Yeah.
Um, that's the dysgraphia. This calcula, thank you for helping me say that, is like to do with the numbers. And then the dyslexia is like this one right here, here, reading and writing. It's something to do with the actual readings going on here. Yeah, yes, mastermind.
So in the question, the thing that stood out to me from the beginning that I was able to rule out B is because he's 13.
Oh, yes, thank you, mastermind. I so appreciate that. And
Oh God,
sometimes
yes. I didn't even think about that.
I love it. And here I was this whole like for 30 minutes, like, and make sure you pay attention to the age. Look at the age. Look at the time frame, right? And then I'm like, thank you, Mastermind, for pointing that out to us. I really appreciate that. Yeah. So, and there's that one too. They gave us the age, right? No, if we could all just take the test together, you see how we would all be able to pass them, right?
Mm-hmm.
Like we Jessica could help us all go faster, and Mastermind could remind me about my old thing I said about when they give us like time frames, right? And Quinique and Jasmine could keep me on track with like going back to the question. Yeah. I'm like, we need to take this as a group. That's for sure. Okay. All right.
The
Quinique.
irony is that I have extra time too.
Oh, you have extra time?
Yeah.
Jessica. Oh my. Well, you know what? Honestly, if I would like to know, do you take the test twice, right? If I saw you again, I'd be like, did you get to go back through the exam twice? I'd be like, you probably have the time, right? I love it. It is so incredible to me. Oh my. Oh, all right. Quinique, do you feel brave enough to take this on? Wait, Quinique, did you just go?
Mm-hmm.
I'm so sorry. Jessica, this is yours.
Okay. A therapist evaluates a 6-year-old girl with moderately severe cerebral palsy. Among other symptoms, the parent report that their daughter is often observed attempting to chew and eat non-food items, including stands, household plants. Sometimes they are able to intervene while she is chewing on the item, but she has been hospitalized on one or more occasions for ingesting leaves from a potentially harmful plant. What is the most likely diagnosis on this case? A. Acroparesis. B. Autism spectrum disorder. C. Rumination disorder. Or D. Pica. I'm going to eliminate A. I'm going to eliminate B. I'm going to eliminate C. And I'm going to go with D.
Yes. Yeah, thank you. And that was our new world record right there. Okay. I'm telling you, Jessica, when I'm hearing you read these questions, I know I said it already, but I literally like at the Olympics, those little timers. I'm like, no, that was our new world record right there. Okay. I love it. Yeah. So I love this sounds terrible. I don't mean I really love this disorder, but I love this disorder for the test because it stands out from all the rest, right? Like you cannot mistake this one. Oh wait. Did you said D, right? Yeah. Okay. I was like, wait. Then I was like, she didn't say C, did she? Right. But that does bring up a good question, guys. What would be the difference between C and D? Like, what would this be describing, or what would have to happen in this question for it to be C?
With C, they throw up or do something, don't
Yeah.
they? Like they chew food and
Yes.
is it
Yeah.
regurgitate or something like
Yep.
that?
It sure
Okay.
is. And this sounds terrible, so I don't mean it that way. But one of the ways I remember it is like what cows do. That just helps me remember
Oh,
like what cows do when cows like that. That's how cows.
Like they'll eat things, break it down, and spit it out. Is that what you mean?
The cows, they literally like chew the cud. So basically, what Quanique was saying, the way it will regurgitate and so forth. I don't know a lot about cows. So if somebody's out there and they know a lot about cows and I just messed that up, I'm sorry. But that's like how I've always thought of it. And I could have that wrong. But I think that's how cows kind of work as well. But that's why I was bringing it up because both of these have to do with like kind of like eating and food. So that's why I was just pointing it out. Pika is like this one, right? Like, I mean, they're going to eat non-food items, just they're eating stuff, right? I mean, it can be very dangerous. Versus rumination disorder also has to do with eating, but they're like regurgitating it and then will eat literally like they're chewing on what they regurgitated. So nice work on that one. Okay, hang in there. Guys, we've almost made it. Look at us. Y'all been great. I really appreciate it. Mastermind, we're back to you. Do you feel up for one more?
Yeah, I can do it. I just need you to like slide the question down. Okay.
Okay.
Okay. Perfect. A couple enters treatment with a therapist due to increasing conflicts and distance after 2 years of marriage. The man reports feeling as if his wife needs his approval for everything, and he's exhausted with her constant worries and questions about what she should do. The woman endorses frequent worries about her husband leaving her or dying young, and states that she only asks his opinion because she trusts him more than I trust myself. The man says that he feels more like a parent than a husband and that this can't continue. The woman's diagnosis is most likely. So you have a couple, husband and wife. You
Mhm.
have a wife that appears to be very dependent on her husband, and the husband is feeling more like a parent instead of a spouse.
Mhm.
And the question wants to know what is the most likely diagnosis. So you have A, avoidant personality disorder, B, histrionic personality disorder, C, dependent personality disorder, or D, generalized anxiety disorder. So I'm going to eliminate D, generalized anxiety disorder, uh, also B, histrionic personality disorder, and between A and C, I'm going to go with C, dependent personality disorder.
Nice job, mastermind. Absolutely. This is definitely dependent personality disorder, like basically the definition of it, right? Where you're always having to, like, you're more submissive, you're always depending on somebody else. You can't do anything on your own opinion, right? Absolutely. Now, in this question, how would you know it would not be like, for example, avoidant personality? Like, what would that sound more like? An
Avoidant,
avoidant personality.
yeah, avoidant personality is a person who wants to be around people, but they fear being around people. They're scared they're going to be ridiculed or teased and things like that. So that's avoidant person. So they avoid people.
Right, because they fear it's more instead of like fearing people, it's more like they fear the rejection. Yes, nice job. Just I would just tweak that one little part there, like for the sake of the test. More like instead of fearing the people, it's more like they fear the rejection by people.
Okay.
Nice work, mastermind. And then I'm
Thank
just
you.
gonna run back up because I delayed processing here about the ADHD, just to make it clear for people. The reason mastermind was mentioning the reason she was mentioning like 12 years of age was pertinent or relevant to this question. So most diagnoses for ADHD will happen between like 6 and 12. That's why she was mentioning, because I think in that question he was what, 13?
Mm-hmm.
Right. So the symptoms have to have begun before 12. And most diagnoses will happen between 6 and 12. Now, that's not to say nobody can ever be diagnosed after that. Okay. Obviously, like there are even adults, right, who are diagnosed. It's just that's why it's relevant. Most people will be diagnosed between like 6 and, or it's common for them to be diagnosed between 6 and 12. And but the symptoms, by the way, for somebody to be diagnosed, they must have begun before 12. And if you get a question like about somebody before like 4, that's not common at all. It is very, very hard to diagnose somebody with ADHD before like 4. So normally the age range is between 6 and 12, and the symptoms had to have started before 12 for it to be like ADHD. So that's I was like, wait, I realized like I was realizing delayed processing. I didn't make that clear why when she brought that age up. That was like so important to like that question. All right, what about histrionic? How would histrionic look, for example, compare? Yeah, that one could
Yes.
be interesting, like in the question.
Histrionic is the person who wants attention by how they dress, like appearance.
Yeah, and drum. They can also act very dramatic too, right?
Yeah.
But yeah, it's kind of like Dr. Pam. I don't know if y'all ever saw that movie where she's talking about the histrionic personality disorder, but Dr. Pam compares it to like somebody, say, with borderline personality disorder, right? And she brings up that image of I think it was Jessica Rabbit or whatever, right? In her like in this like very alluring gown, and she's like, this would be more histrionic, like, right? They're more likely, she said, to be like very attention getting in how they dress. And she said the strange thing, Dr. Pam said the strange thing is, in this video she has, I don't remember the name of this video, is that even though they might dress or look that way, they're less likely to actually be sleeping with different people than somebody with borderline personality disorder. So I don't know if that, I guess I can help you in some of the questions. Otherwise, she wouldn't have mentioned it. Dr. Pam only mentions stuff that can help you in questions. So that has always stood out to me. The histrionic, she was comparing to the borderline personality disorder. But I can't tell you which video that was in for you to go find it for yourself. So, well, all right, y'all. do you want me to also send you these questions? Let's see if these will attach. Want to in the chat. Let's see here. Um, okay. Attach. Okay. Okay. I've been having the hardest time with stuff not wanting to attach today and last night. Like Thursday, it was fine. I did a group Thursday, everything worked fine. And then like last night and today. So can y'all let me know if this one is working? Or is it requiring me to give you access again? It's not working at all. Oh, you're on. Your mic is off, Jessica.
Mine is
It's
working.
good.
Okay.
And it just requires access to like edit. So you could print from it, it says.
Oh, oh, cool. Do y'all need access or are y'all good with
No
it? Like,
access.
you need access? Okay. If you just send it to me again, let me check my email right quick. Interesting. Okay, where is it coming from? I don't see any request, y'all. Interesting. You know what I might can do? Yeah, it's so weird, y'all. I'm not getting any.
I didn't need access. I only needed access to,
Oh, I
yeah, I only
see.
needed access if I wanted to edit it, but you're able to
Okay.
print it.
Oh, thank you for letting me know that. Okay, so for future reference, if for whatever reason these do not work, I don't know, something weird happens. Tech is weird some days, right? Sometimes stuff just goes weird. Like I put my email in earlier. Just feel free to email me and I'll send you the documents, right? And they might send them out too, right? A lot of times, the scheduling, the admin people, they also send out the recordings and the documents. But if there for some reason there's something you want or need and you don't get it, you can also just reach out and I'll like send it to you again, okay? All right. Well, y'all, I think this is the end of our time. I think I've tortured you enough. Okay. Was this enough torture?
Well, it was a great session. I appreciate it. I learned a lot. And yeah, I like your sessions. I told Dr. Pam last time, I was like, yeah, Sarah, she cool. I like her. I like her a lot.
Oh,
Yeah.
thank you, Mastermind.
Yeah.
Thank
I
you.
appreciate you. I love Dr. Pam, but if I wasn't on Dr. Pam's schedule, I definitely would get on your schedule.
Oh, I am a diehard Dr. Pam fan
Yeah.
all the way. She is the reason I passed and now I can be there. Like
Did
I
you
would
pass
still
the
be back
first
trying to
time?
pass the test.
Did
Do
you
what
pass
now?
the first time?
Well, I did, but I can tell you the only reason why, I promise, I'm not just saying this either for like a commercial or something, right? Is because I found Dr. Pam and then whatever Dr. Pam told me to do, like I just like did it religiously. I mean, it was like my family, I think they thought I found a cult, you know? It's like Dr. Pam said this.
Yeah.
Dr. Pam, they're like, oh my goodness, like what cult is this, right? I'm like, Dr. Pam, Dr.
Yeah.
Pam.
Yeah.
But the truth is, I was like, you know what? I'm just gonna see if it works. Like I just got out of my own way because I literally had to get out of my own way. That is a true story. I was like, no, whatever she says and my coaches, I'm just gonna really do what they say and just see if it works. And it worked so well that when I passed, like I wanted to help other people because it was so hard for me to pass at first, like to get the material. It was so hard. And like the resources I first had were not working. And thankfully, I found Dr. Pam before I took the real test. What happened? I took a practice test and I totally bombed it. And I was like, I am in trouble because I have been studying and studying and studying. And I realized whatever I'm studying or how I'm doing this is not going to work. Like if I can't pass a practice test, I can't go take the test and pass. So, but that's the only reason why. But yeah. So then I was like, it worked so well for me. I'm going to help. I wanted to help other people. So like I'm a therapist, right? Like I got licensed, but I do this like too, like on the side to help because I just want to see other people pass now. I remember what it was like. It was a nightmare for me at first.
Yeah. Well,
But
thank
thank
you.
you for the kind words,
Yeah.
Mastermind.
You're
It
welcome.
means a lot to me.
Yeah.
All right. Well, y'all, good
Bye.
luck.
All right.
Good luck
Thank you.
studying. Bye
All
for
right.
now.
Good night, everybody.
Good night.
Good night.